Okay, so hi everyone, good evening. My name is Ankita Bhattacharya. I'm a PhD scholar at IIT Kanpur, and as you already know, the course that we will be covering is about advanced concepts in cancer biology and precision medicine. So I'm going to share my screen in the presentation mode now. Please let me know if anybody is not able to see it so that we can sort that out before, so that we can sort it out before proceeding forward. Okay. So before we get into details about the course directly, first, what I actually want to discuss with you guys is that I currently work on cancer biology. That is what my research area focuses on. That is why I chose this course. And what I would like you all, if any of you are interested, which I think you were based on your feedback from the Google form, if any of you are interested in pursuing a career in this direction, please let me know if I can help you figure out something. If you want to know opportunities, we will be having a brief discussion session towards the end of every session. So you can let me know that, or you can drop me an email and we can discuss that as well. Apart from that, as you already are aware, this entire course is of 24 hours. So we'll be having approximately 4 hours of discussion every week. This will basically be centered around discussing some core topics. When I say core topics, I mean that we will be starting off with the very basics of cancer biology because I'm not sure how each of you have previously learned or have had first-hand experience working in the field of cancer biology. So it's always better to get everybody on the same page about some very basic concepts, which is what we'll basically be covering today. And following that, in the upcoming weeks, we'll be delving into more precise topics, more relevant to current research areas or current, say, for example, advances. If you've gone through the flyer, I have mentioned about diagnostic techniques, about different combinatorial therapies, etc., drug resistance that has come about. So we'll be learning about all of those as well. And also, what I would very strongly encourage is for anybody to stop and interrupt me at any point of time if you have any query or if you want me to repeat something, explain something again, please let me know. And if you have any feedback about the class, please let me know that as well, that you want certain types of discussions to be prioritized over others. Say, for example, you want sample questions, you want some experimental techniques, etc. Just let me know and we will, discuss that over the duration of the course. So with this introduction in mind, let us go ahead. So first of all, this is the first week's lecture. So if you have gone through the flyer, you would have seen that these are the overall idea of the topics we will be covering. So the first topic that is the major focus for our class today is about the hallmarks of cancer and understanding how cancer cells actually become cancerous. And progressively, as we go through the course, we will be learning about signaling pathways, methods of detection, starting off with the traditional methods and the traditional strategies which are used for treating patients. Then the current advances that have occurred over, say, the last decade or the last 2 decades, and how every year, every month for that matter, new strategies are coming up. What is the need for those new strategies, and how we are shifting from a more generalized approach for cancer treatment towards the concept of precision medicine. We'll be learning about all of that. And we will also understand some terminologies. When I say cancer statistics, there's a field within cancer biology whereby basically whatever research is being done in oncology labs that needs to be presented. So for their presentation, you have to give certain statistics. When I say statistics, there are certain measurements or certain parameters. So we'll understand all of those because that might be more relevant for somebody who is hopefully looking forward to work in a clinical setting or is looking forward to work in academia. And finally, this topic is something that we will be discussing in a lot of detail. That is about understanding cancer evolution and drug resistance. And under this concept itself, we'll cover this in probably two classes instead of one because it's quite a diverse field. And under the scope of this class itself or this topic itself, I will also be introducing some currently used genomic techniques. If you are familiar with the idea of genomics, basically it talks about all of these sequencing technologies because if you have heard about next generation sequencing or NGS, RNA sequencing, DNA sequencing, proteomic profiling, methylome profiling, all of these techniques are being extensively used in today's time. My lab also works on that as well. And it is very, very relevant because it is able to give you a huge repository or a huge stock of information of patients across the world, across different populations. So we'll learn about those techniques as well and how they have helped us understand that cancer evolves and why there is a resistance towards the treatment strategies that we usually take up. So this is the broad idea of the course. Keep in mind that I will start off with a very basic idea of cancer in today's session. And progressively, if at any point you feel that I am speaking too fast or maybe something is beyond your understanding, please don't hesitate. Please interrupt and ask me any query that you might have. So with this introduction, if anyone has any questions, any suggestions, any input, please let me know. You can stop me at any point of time. Just raise your hand or you can directly unmute and ask me or drop your question in the chat box, whatever is convenient for you. Okay. So in today's session, broadly, these are the topics that we are hoping to cover. First of all, we understand the introduction to cancer, some key terminology, some key definitions so that we have it straightened among all of us. We'll go through a quick recap. We will understand the classification of cancer, what are the different types and subtypes of this disease. We will also understand some key terminologies for oncology. Why these terminologies are relevant, you'll understand over today's class itself. And finally, the main question that we want to understand and look at today are the hallmarks of cancer. So with this in mind, let us move ahead. First of all, what is this disease also very commonly known as? The emperor of all maladies. This is a very common terminology which is used for cancer. And by definition, if you talk about cancer, it is considered to be a disease of uncontrolled proliferation by transformed cells subject to evolution by natural selection. Now, this definition might be a little confusing to all of you. You might just think of it as a disease which causes tumors. But why these terminologies or why this jargon or these exact words are relevant, you'll understand that over the period of the course. Basically, what we usually understand cancer by is this terminology, whereby we call a disease, cancer, as a disease of uncontrolled cell proliferation. What does that mean? So if you talk about normal cell proliferation, this is how normal cells divide, whereby they go through several substeps, majorly in two types of processes, one of which is known as mitosis, the other one is known as meiosis. If you're not familiar with it, please let me know. I'll go through the definitions very quickly. So basically, there are two types of cell division. As you can see, if you look closely through the GIF image, you'll be able to see that there's a subdivision or there's a constant division between these two cells. So initially, there is one parent cell from which there's division of the entire genetic material, either equally or there is a reductional division depending upon whether a cell is undergoing mitosis or meiosis, and then normal cells are divided. So the daughter cells which are generated will carry the correct information from the parent cell, and this is a necessary process that occurs in almost all cells of your body throughout your life, and it is necessary to keep you alive, keep you functional, and to allow cell generation constantly. Now, when I say almost, this is because you might be aware that not all cells within our body are dividing. If anybody knows of any examples of cells which are not dividing under normal circumstances or which are dead cells, you can let me know at this point of time. Apart from that, there is another thing that you need to understand. this entire process of cell division that you are seeing seems to be a very easy, like a very obvious and a very default protocol which is being followed. But that's not the case. Every substep within mitosis or within meiosis involves several checkpoints. What are these checkpoints? Checkpoints basically mean that within the cell, there are, think of them as traffic signals. There are several traffic signals which have been put in place to ensure that a cell that is undergoing division is healthy, has the correct DNA, does not pass on any unnecessary or any junk DNA or any incorrect DNA to the daughter cell. Why that is necessary? It's necessary for the cell to ensure that only correct cells are dividing or healthy cells are dividing and other cells are removed by natural selection. That is how nature has basically installed this system of checking the cell at every point during division. Now, what happens in cancer? If you look at this image, this is an actual image of some cancer cell line which is undergoing very rapid division, as you can see. And as a result, this entire process, which you most commonly know of, is called as an uncontrolled method or uncontrolled process of cell proliferation. Now, this only occurs when cells have undergone transformation. What sort of transformation do they undergo? This is a major question we'll be answering in today's class when we discuss the hallmarks of cancer. Apart from that, this definition also says that cancer cells undergo evolution by natural selection. Does it actually occur? Well, the short answer to that is yes, cancer cells evolve, and that is the reason they are able to outcompete all of the treatment strategies that we have been able to design till date. So think of it in this way. Most of the diseases that have some dedicated scientists or dedicated research groups working on, helping people or helping patients of that disease, they eventually get sorted out. Think about even extreme diseases like, for example, HIV, chickenpox, all of these diseases, maybe not chickenpox, smallpox for that matter, they all have vaccines designed. And, eventually, after a period of time, some decades later, there has been some sort of respite for people who suffer from the disease, and then they're able to go back to their healthy state. But when we hear about cancer, in uh, let's say 8 out of 10 cases, you will hear that there is some sort of relapse or patients, they do not recover, or, they progressively become much worse. And the disease most often leads to extremely, extremely poor outcomes. Therefore, the consequence of the disease in most cases is very poor, very negative, and patients are barely able to make it through. There are, of course, good reports as well, and a lot of people survive it as well. Now, the major contributor to this disease being so severe and so fatal is the fact that these cells are able to evolve, which means that based on what sort of conditions you are subjecting that cell to. When I say conditions, say, for example, suppose I have, a particular type of cancer and I'm undergoing chemotherapeutic treatment for that disease. Now, over a period of time, because chemo itself also is a very long process of several months where patients are administered whatever medicines are necessary for that type of cancer over a period of, say, 6 months or 1 year, depending upon how severe the cancer is. Now, what happens is that over time, because cancer cells are undergoing proliferation in a very haphazard, very uncontrolled manner, out of the entire population of tumor cells, there might be some cells which have modified themselves in a way which allows them to survive in that condition, which means that despite the fact that the patient is being treated with that drug, these cells have figured out a way to withstand that drug, and now they're able to survive even better. What will then happen is, by the process of natural selection, those cells will now be selected. This is the phenomenon which I've explained in fairly basic language, is the phenomenon of drug resistance. So despite the fact that you are giving drugs, your cells are evolving or your cells are changing so as to survive that drug and then even make the cancer even more severe. So all of this we'll discuss in more detail, don't worry. But to answer this question very briefly, yes, they do evolve. And how they undergo transformation is something we'll address later on. But basically, these are the two scientists who should be definitely credited with this understanding of how cancer cells transform. So again, just to make you a little more familiar with how research works, um, when we talk about a disease, or rather a disorder as complicated or as widely varying as cancer, it's never enough for one group to work on it. So scientists across the world have made immense number of contributions. If you just go to PubMed, which is a repository for scientific papers, and you search for cancer, you'll find uncountable number of papers that are actually working on this disease actively even today. Just go back in the last month and check, and you'll find thousands and thousands of papers. So all of this was assimilated and then presented as a very, as an easier way of understanding by these two scientists, Professor Douglas Hanahan and Professor Robert Weinberg. They are the two scientists who have proposed the hallmarks of cancer. And you can, if you are familiar with it or you're keen to read about it, these are the three articles in which they have actually published subsequently the idea of cancer, which was relevant at that point of time. So they started off in the year 2000. And then every 10 or 11 years, a new article, or basically it's like an update on what is the world aware about cancer at this point of time. So somewhere around 2030, 32 or 33, we can expect the next article, and that will summarize the more, the additional ideas about cancer that we know in that point of time in the future. So this is the basic introduction. Now let us understand the progression of cancer. We have understood what the disease is defined as, and we've understood some key aspects about it. So this schematic will actually represent the it's a representation of the different stages that cancer undergoes over a period of time. It's not necessary that each one of them will be undergone, or there are all of these different stages or substages you can recognize in each patient. In most cases, you actually don't. Cancer is usually diagnosed at very later stages because symptoms, the symptoms are not very easily distinguishable. In most cases, people feel weakness, they experience a lot of vomiting and very basic symptoms, which you normally would never attribute to cancer. So that's why its diagnosis is very late. And in most cases, it is diagnosed at a stage where it has progressed very far, and it is either in a pre-invasive or pre-invasive state, or it has already metastasized. So that's just the reality of it. But physiologically speaking, within the human body, the different stages that actually occur, they start off with a simple substep known as initiation, following which there are substages known as hyperplasia, dysplasia, in situ cancer, all of which, don't worry, we'll be discussing in more detail in the upcoming slides. And then this in situ cancer becomes more severe, more serious, or more aggressive, which is known as invasive cancer. And then it metastasizes, or it undergoes metastasis. So again, let me remind you, if you do not understand what I'm saying at any point of time, please let me know. I might be speaking a little fast. I'll try to explain things better, but just interrupt me if anything is unclear at any point of time. So if we talk about the first step, which is initiation, what does it mean? It means that within your body, cancer arises from your own cells. It is never something exterior. It's not a pathogen that has come into your body that you can just eliminate, taking an antibiotic or taking some anti-helminth or something like that. It's your own cell. That's why targeting cancer, and when I say targeting, it means that selectively only harming the cells which are cancerous and not harming your own cells is a challenge that we face even today. Till date, even the most advanced techniques in a lot of cases have actually not been able to optimize this specificity that only cancer cells die and your own cells remain unaffected. So that is a huge, huge challenge. And it's something that we are working on, and hopefully the future holds something good for us. So your own, here in this example, you are looking at epithelial cells. So our own epithelial cells, in a lot of cases, undergo some sort of a mutation. In most cases, this is the most common way in which cancer arises. That is because of a genetic mutation. There can be other sources also. There can be some copy number amplification. There can be exposure to radiation. So in a lot of cases, people who are very frequently exposed to X-rays, or who undergo a lot of, who are subject to some sort of ionizing radiation or some radioactive material, even though in today's time that has been abolished to a large extent. But people who are basically exposed to all of these sources, commonly known as mutagens. Mutagen is literally any chemical which can cause a mutation within our genetic material, which is our DNA. So any exposure to such mutagens can lead to initiation of this oncogenic event. When I say oncogenic event, it means oncogenic, the term by itself means cancer causing. So a cancer causing event mostly arises from these sort of genetic mutations. This is the most common cause. Following that, it undergoes several substages. You can see that from that one mutation, uncontrolled cell proliferation has occurred in a local manner where a cell divides more rapidly than normal. Following which, within that mass, you can find that there are some subset of cells which are dividing even faster, and they have been selected for, and they can actually take over the division of the other cells. So these are leading to the formation of an even bigger mass, which is undergoing very rapid division, and this is called as in situ cancer. In situ means inside. It means at the location where the cancer had arisen, where it had first started, at that very location, a bigger mass has divided and it has formed sort of a like a tumor, but it is still present in that initial site. However, after this is what you actually call as cancer. This is considered to be a precancerous stage. So cells have divided, they have formed a mass, but they have still not become cancerous. Why so? That is because they may or may not eventually get removed from the body. In the worst case scenario where they are not getting removed, what they can start doing is they can start invading. What does invasion mean? Invasion basically means, um, think about this. This is your epithelial lining. Epithelial lining can be epithelium of any part of your body. Say it is your skin. It can be our inner lining of the gut or your stomach. It can be your mouth lining, any of those things, right? So what happens in those linings is that these cells are all arranged in this, beautifully sequential and organized manner. However, what happens is these cells are placed on another layer. This layer is called as the basement membrane or the extracellular matrix. How do I explain it? Think of it as some sort of a support system on which all of these cells are placed. So this is essential for those cells to be, for the integrity of those cells to be maintained and for the tissue to remain intact. But what happens is that during cancer, cells are able to disrupt this exact membrane, this support system, and they are breaching it. When I say breaching, it means they just think of it as they are removing the barrier and they're able to move through this layer. As a result of that, now what happens is they can move into the tissue. One of the most common things that happens in this circumstance is that they are able to enter into the nearby blood vessels. This is a very difficult to treat and a very common response of cancer, because when it enters into the blood vessel, it can move into any part of your body, right? Because if you know about the circulatory system, every part of your body receives oxygen and nutrients based on the nutrition that is carried from this blood vessel, and based on the oxygen which your RBCs carry for you. So once cancer cells have gone into the circulation, they can move into any place within the body, and whichever place they find to be, suitable or good for their growth, they will settle down there and they will start forming more and more and more and more tumors. And that is what happens during metastasis. So if you I hope you haven't, but if you've ever come across somebody who has been diagnosed with cancer, there are different stages which are known. We will be discussing this when we talk about cancer statistics, that there are stages, stage 1, stage 2, stage 3, stage 4. All of these different categories have been subdivided, and the reason or the logic behind it is based on how far the cancer has spread, and some pathological staining is also done. So all of that together is used to explain to the patient how severe the disease is and what is the expected lifespan that they can make it through. So in patients who have undergone extensive metastasis whereby throughout their body cancer has spread, so in those cases organ function is compromised and patients do not usually make it through. So these are the different substeps. I know I'm making it sound a little gloomy, but this disease is that serious. It is that severe, and you must give it the respect that it deserves. And also, if you are interested in cancer, you will love the disease because it will make you so curious and it will make you so um, it will inspire you to be very determined and to persist in a place which is not allowing you to stay there. So with this, let us move ahead because I have a lot of slides in place. I think I'm going a little slow, but we'll take it one slide at a time. Coming to some key terminologies. So I told you I'll be discussing about hyperplasia and dysplasia. So this is where we discuss it. So here you can see the schematic representation of a normal tissue. Let me zoom in a little bit. It's not very clear. But yeah, basically you can see that this is the section. Think of it as a section of your skin. If you have studied biology in class 11, class 12, or even in your first year of undergraduate schooling, so there basically we see all of these sections of human tissues. So basically this is the epithelial lining, and under the epithelial lining you can see all of these cells. They are arranged in different manners. So this is the normal regular arrangement of these cells. Next, what is happening? Oh, sorry. Next, what is happening is that there is a substage which is known as hyperplasia, and that hyperplasia leads to a very rapid cell division. Very rapid cell division leads to the formation of hyperplasia. So that term by itself, you can see hyper means excessive, plasia means there is a increase or excessive division or excessive number of cells. So hyperplasia occurs when cells within a tissue multiply faster than normal and extra cells build up. However, the cells and the way the tissue organization appears is normal under the microscope. So the appearance of the cells are pretty much normal. However, the number of cells has increased. Keep in mind there is another terminology and you should not get confused between these two. This is hyperplasia. There is another terminology which is known as hypertrophy. Um, you might have come across it. It is also sometimes mentioned in context of cell division, but basically hypertrophy is a condition where the cell size is increasing. So one cell is becoming huge, the nucleus of the cell is huge, the cytoplasm of the cell is huge, but it is not a hyperplastic growth. It is not a precancerous stage or a pre-neoplastic stage. So there's a difference between these two. The next substage is known as dysplasia, which is a lot more advanced. In dysplasia, you are seeing that there is a buildup of extra cells as well. But what is different is that they appear abnormal and the tissue organization is completely lost. So here you can see in the normal cell, there is a difference between the different sublayers within the tissue. So you can see there are one type of cells which are closer to the surface, some which are in the middle, and some which are closer towards the cortex. They're arranged differently. And that is necessary for the tissue to function and to stay in a normal condition. But in the dysplastic tissue, you can see that all of these cells, they look very different from the first one, and they have completely taken over the tissue. So one major point of difference that I would like you to point out. Can anybody unmute and let me know what do you think is the major difference apart from the organization, just based on the image between the normal and dysplastic tissue? Can you tell me what is the major difference if anybody would like to interact? Don't hesitate. I'm also a student, much like you. So just whatever you know, it can be right, it can be wrong. If you contribute, that would be interesting. Okay. Nobody?
Ma'am, size of the nucleus?
Correct. Exactly what I wanted. Just a second. I think somebody got locked out. Yes, you're absolutely correct. So, one of the major point of differences between a normal and a cancerous tissue is exactly this. If I speak in a more semantics or jargon-based manner, this is called as a nucleus to cytoplasmic ratio. So, for a normal cell, you can see that there is a balance between the nucleus and the cytoplasm. That is because the cytoplasm is not just an empty, it's not like a soup that doesn't have nothing, it just has some fluid or something like that. No, the cytoplasm is filled with relevant components of the cell, starting off with organelles, the cell skeleton, otherwise also known as the cytoskeleton. It has hundreds and thousands of vesicles, which are necessary for transport and a lot of other things. So that is necessary for a cell to divide, function, and survive normally. However, in a different tissue, which is a pre-neoplastic tissue or a cancerous tissue for that matter, this ratio or this balance is completely lost. As you can see, the cell nucleus takes over. Why does this happen? Because the nucleus is dividing abnormally, it is dividing rapidly, and it no longer prioritizes the health of the cell, but instead all it just prioritizes is increasing in number and taking over the normal cell resources, hijacking the normal cell resources, and just proliferating indefinitely. So you are absolutely correct. I think Vaishnavi answered right. You were absolutely correct. So that is the major difference. So when a person is in a lot of cases, you might have heard that people undergo biopsy, right? So biopsy basically means they use like a syringe sort of a structure to pull out or to punch out a portion of a tissue. Say, for example, in people who have oral cancer, so a part of their tongue is punched out. It's a tissue which is taken. Then that is sectioned and imaged, stained and imaged, and then you can see these differences. So pathologists are able to actually categorize based on what type of cell morphology is visible. And one major change is this A, abnormal organization, and of course that nucleocytoplasmic ratio. And you can see it gets much worse in the cancerous tissue. I have also included some actual images. This was because this was a schematic representation. This is an actual image of patient tissues. So this you can see is the normal skin. If I zoom in a little bit, you can see that there is a lot of organization that is present. It might look haphazard to you, but you can see that there are cells localized in different regions. Like if you see the cells at the surface, they're quite different from those in the middle. And somewhere in the middle, you can see some different cell types also present. All of this is necessary for normal function. Now, in a cell, in a tissue which has undergone epidermal hyperplasia, you can see that this organization is completely lost and cells have increased haphazardly and formed just random divisions. But what is even worse is this dysplasia. So here a comparison is presented. So sorry. Here a comparison is presented between low-grade dysplasia, which is more mild, to moderate to high-grade dysplasia. And finally, carcinoma in situ. So you might not be able to distinguish between those different stages, but basically what you can see is that the tissue organization from the normal tissue, so sorry, yeah, from the normal tissue, the organization is lost and there are very large enucleated cells which are taking over and the tissue normal morphology is completely gone. Finally, here you can, if I zoom in a little bit, maybe you'll be able to see. Yeah. So can you see like a smaller mass, a smaller region which has even larger nuclei? That is also often seen. And in fact, in a lot of cases, cancer cells also have multiple nuclei or multinucleate cells. And that is because they have lost that control that one cell is supposed to have one normal nucleus and instead they just keep on dividing rapidly and they have more and more DNA which is present, and then they can hijack all the normal machinery of a normal cell and they just function in an uncontrollable manner. So these are some common morphological features which are usually used to distinguish a normal cell from a cancerous cell. Now here, yeah. Now we'll go into a little more detail about some terminologies relevant to oncology. So first of all, tumor classification. Tumors can be classified into two broad categories based on how aggressive the growth is. If they grow locally without invading any adjacent tissues, they are termed as benign. Others, which invade adjacent tissues and they give rise to metastasis, are called malignant. Now, you might say that metastasis is a process. How can something give rise to a process? So, again, these are two terminologies that you need to clear. When you have metastasis, which is metastasis, that is the process of metastasizing, the process of spreading throughout the body. Metastases, when you have an E instead of an I, is basically those secondary tumors. So from the first tumor, the primary tumor, when there are several smaller growths, when it has spread throughout the body, it is giving rise to something called as secondary metastasis or secondary tumor, otherwise also known as metastasis in general. Within that, there are also subclassifications, which are known as macrometastases and micrometastases. So that depends upon the dimension and how fast it has spread, how extensively it has spread. Those are definitions you can avoid for now, but if it interests you, you can certainly read about it. But basically, what I wanted to highlight was the key difference between benign versus a malignant tumor. Again, these are terminologies you might have heard of before. Benign tumor, you might hear of a lot of people who undergo surgery because they have a tumor and then they're completely fine. That is because their tumor was benign in nature. It was only located within, say, for example, um, in a lot of cases, people have gallbladder cancer. Uh, Especially, it is very popular among the like the northern belt, like where I reside, around Uttar Pradesh, Uttarakhand, all of these regions. In women, especially, they're very prone to this disease. So, in cases where they are diagnosed relatively early on, simply the gallbladder is removed from the body. In a large number of cases, patients recover just fine. However, if it is something like, say, for example, somebody has been diagnosed with stage 4 glioblastoma. Glioblastoma is cancer of the brain. So obviously, you cannot remove the brain. And if it is a cancer which has spread throughout the brain, then how much of it can you actually surgically operate on without killing that person? So in those cases, they're very severe. They have formed multiple metastases. It might have spread from the brain to other regions of the body, through the lung, to the lung, liver, which are most common sites, to the bones. In a lot of cases, we hear that patients who are in their in more advanced stages of cancer, they have bone metastasis, and in those cases, of course, removing a bone is not possible. So they are subjected to radiation therapy, chemotherapy, etc. But in those cases, disease is extremely aggressive, as you can understand, and of course, it is a malignant form of cancer, and it is very severe. So these are the two terminologies. And also just superficially explaining it to you, benign tumors are usually operable. They can be surgically removed. Malignant tumors are usually not operable. Even if they are because they have spread at multiple sites within the body. It's not usually advisable to go for surgical excision, but instead to go for some sort of an external therapy. So, yeah. Now we'll come to the subclassification of tumors based on what type of or what source they have actually been or they have actually originated from. So based on the cell type or the source of tumor origin, cancers can be classified into several subtypes. The first one is carcinoma. Now, this I especially wanted to discuss with you guys because in most cases, we use cancer and carcinoma interchangeably, but that is not always the case. It's just that carcinoma is the most common type. Like if you go to a hospital, unfortunately, I hope you don't have to, but if you go to an hospital and you go through records, you'll find that most people have some sort of a carcinoma itself. It's relatively rarer for people to suffer from leukemias. In our country, melanoma is not something that happens very frequently because we usually have more melanin within our bodies, so that's more protective against the sun. But in the Caucasian cohort in Western countries, because of the lack of melanin, melanoma becomes the most commonly diagnosed. You'll find it like in almost every household, somebody suffers from melanoma. Apart from that, sarcomas, etc., these are less commonly diagnosed. So that's why I wanted to clarify these terminologies with you. Carcinoma is only when we talk about tumors that arise from epithelial cells, which are the cells that cover the interior and, sorry, that's an error, interior and exterior surfaces of the body. Only these tumors will be called as carcinomas, and they are the most common type of cancer. Why this is something which I want you to understand is because when we think about epithelium, mostly we just think about the skin or the surface, but your inner lining, if you have studied developmental biology at any point of time, you would understand this better, but it's okay either way. But basically, we are think of us like a pipe. Like we have an inner surface, the inner cylinder, the outer cylinder. So both of these epithelial surfaces are extremely capable and extremely prone to getting cancer. When I say prone, it is because in today's time we are exposed to a lot more mutagens compared to the kind of conditions that our parents, grandparents used to live in. So yeah, both these surfaces are usually commonly found to have cancer. Um, Among carcinomas, what I wanted to especially define with you guys, even though we have discussed it already, is the carcinoma in situ, which is CIS, and it is a group of abnormal cells that are found only in the place where they first formed. This is, you must see this panel, and you can see that there is an outer tissue layer, muscle layer, connective tissue, inner tissue layer, and within this inner tissue layer, you can see this abnormal mass of cells which are only localized within that site. They have not invaded, they have not moved into other parts of the body, and they are just localized at that position. This is a carcinoma in situ, whereas this is a condition where it is cancer, and you can see that it has invaded the inner tissue, connective tissue, and the muscle layer. So multiple tissue layers have been disrupted, and a giant mass of cells have been formed, which are abnormal, and they are eventually, of course, going to take over, that entire location. Also, yeah, also I'll if you have ever come across people like this, I think most of us have, a lot of people have outgrowths in these locations, like around the neck, sometimes lumps in the head, or, just random lumps within the body. So you should understand that not every mass is cancer. That's a very common assumption that people have. In a lot of cases, it is cancer, but not everything is cancer. Sometimes it is just a buildup of fluid. It might be just, lipid deposition, which occurs in a lot of cases. In a lot, when it is around the neck, it occurs sometimes due to cholesterol. To you is because when you are learning cancer biology, if you are eventually working in this field, people will also consider you to be responsible. So what your knowledge that you possess, you should also distribute that knowledge responsibly, and you should not uh, loosely throw away terms, because somebody might trust your words, and it should be correct. You should be responsible for your words. So that's why I was just trying to explain that it's nothing to be worried about, but just, yeah, be a little careful. And for your own academic understanding, this is the difference between carcinoma in situ and cancer. Now, coming to cancer subtypes in a little more detail. So, carcinomas that begin in different epithelial cell types have some specific names. If it is confusing, don't worry. I'll be sharing slides with you. It'll be uploaded on YouTube as well. So you can go back and refer to it at any point of time. So the first subtype, most commonly known and understood, is the adenocarcinoma. Adenocarcinoma is cancer that forms in the epithelial cells that are responsible for producing fluids or mucus. So these are mostly secretory cells. They produce fluids or they produce mucus, and these they are present within tissues which are often called as glandular tissues. You might be familiar with the term glands. These Yeah. Hi. I'm so sorry. I think something went wrong with the internet, so it got disconnected. But yeah, this is what we were discussing. I hope you can see my screen. If not, please just interrupt me and let me know that it's not working. So yeah, we were talking about adenocarcinomas. So they are usually formed in tissues which are known as glandular tissues, basically parts of glands. And this actually covers the most common cancers that you hear of, which includes breast, colon, prostate, all of these organs. And they are very abundant in most populations, even within the Indian population. And just to let you know, the cancer that I work on is prostate cancer, which is very prevalent in males, especially in our country. So that is the tissue that I work with. So all of these are adenocarcinomas. Apart from that, yeah, here you can see at the bottom, this is a representation of colorectal adenocarcinoma. Why colorectal? Because most of the time, if you just recollect your basic physiology of like class 5, class 6, you'll remember that the colon and the rectum, they are connected, and therefore more often than not, when cancer arises in the rectum or within the some part of the colon, it usually spreads, and therefore they are considered as a common system. So this is just a representative image of colorectal adenocarcinoma. Apart from this, the next less common, but less common in our cohort in the Indian population, but very common overall across the world, is basal cell carcinoma. As the name suggests, basal basically means the lowermost layer of the epidermis, which is the person's outer layer of the skin. So if this is confusing, just basically think of yourself as the cylinder. So the basal layer of the epidermis is the outermost layer. So it is most commonly visible, like externally visible. Colorectal adenocarcinoma is something you'll diagnose very much later on when it is leading to other sort of symptoms. People, see blood in their stool, people experience blood and vomiting, etc. When all of these things happen, then these cancers get diagnosed. But of course, this is a superficial form of cancer, so it can be identified a lot more easily. So yeah, this is basal cell carcinoma. Again, it might just simply look like, a pimple or just some sort of a basic abrasion, but yeah, it's carcinoma. That's why this is something you might be, if you're familiar with Western culture, you might have seen it that people recommend you should get your moles checked, you should go to a dermatologist very regularly. But yeah, again, I must iterate, it is very uncommon in the Indian population. Not that it doesn't happen, but it is just relatively uncommon in our population. But yeah, you can never be too cautious. So that was the basal cell carcinoma. Next comes squamous cell carcinoma, which is a cancer that forms, as you can obviously understand by the name, in squamous cells, which are epithelial cells lying just beneath the outer surface of the skin. So basal cell are at the bottommost, and above that are squamous cell carcinoma. So if you think of yourself, your outermost layer is involves your basal cells, the layer beneath. Squamous cells also, they line many other organs, including the stomach, intestines, lungs, bladder, kidneys. Squamous cells look flat like fish scales when viewed under a microscope, and sometimes they're also called as epidermoid carcinomas. That's just another nomenclature for it. But yeah, again, keep in mind, these are just representative images. Basal cell carcinoma can look like anything. It can just look like some sort of just a brown patch, and it's actually cancer. So yeah, these are just representations, just for you to understand it a little better. And finally, among carcinomas, the last subtype, which is a little less commonly known of, is transitional cell carcinoma, which is a cancer that arises in epithelial tissue called as transitional epithelium or urothelium. This tissue is made up of many layers of epithelial cells that can become bigger, smaller, and is most commonly abundant in the bladder, ureters, part of the kidneys, also known as the renal pelvis, and a few other organs. And these are most commonly transitional. It's just basically depending upon the cell type that these subclassifications have been made. And this is a representative image of the same. If you zoom in, you'll be able to see to see that there's a loss of nuclear polarity where cells they do not mature towards the surface. Cells exhibit large, irregular, hyperchromatic nuclei. What does hyperchromatic mean? Chrome, when the terminology chroma or chrome comes in, it basically means that the cells are just give me a second. Uh, am I audible? I think my internet is just troubling me. Let me know if you can't hear me at any point of time. Yeah, I hope it'll be fine now. Okay. So, yeah, we talked about transitional cell carcinomas as well. So just to quickly revise it, we first started off with cancer by itself. We talked about benign and malignant forms of cancer, surgically operable, not operable, easier to treat, more difficult to treat. That was the basic classification. Then we came to, depending upon the cell origin, the different subtypes, and we have only discussed the first subtype, which is carcinoma, that arises from epithelial cells. Among that, we talked about adenocarcinoma from glandular tissue cells, basal cell carcinoma from the basal layer of the epidermis, squamous cell carcinoma from the squamous cells, and transitional cell carcinoma, obviously, from the transitional cells. We have examples for each of these. You can go back to the slides and refer at any point of time. If there's any doubt, please interrupt. Please let me know. I'll try to address it as the best I can, and I'll come back with more material that can be helpful for you in the next class if needed. Also, I have in every slide, I have cited the source from which I have taken this information. Like, for example, here you can see NCI Dictionary of Cancer Terms. So that's a wonderful resource to just quickly study, just get to, if you want to just Google a term, a reliable source of Googling a term is the NCI. There is a repository known as NCI Cancer. So there you can, it's easy to understand, like somebody who has no background in cancer can also understand it. But of course, if you're more interested, research papers are always the way to go. But depending upon your understanding, you can choose whatever is working for you. Now, we'll come to the next subtype, which are sarcomas. So sarcomas are cancers that form in bone and soft tissues. Again, quick recap. The first one we talked about was from epithelial cells. Sarcomas, on the other hand, are from bones and the soft tissues of your body. What does it include? Muscles, fat, blood vessels, lymph vessels, fibrous tissues like tendons and ligaments. So basically, again, just to give you perspective, any cell within your body has the capacity to become cancerous. Yeah, of course, till date, we have not exactly heard about sperms being cancerous, but certainly you have heard about ovaries being cancerous, you have heard about testicular cancers. So the source or the organ any organ within your body can become cancerous. That is because they are basically cells. And as soon as the cell, um, the control over the cell is lost, cancer can arise in that tissue. Now, among sarcomas, these are two common examples that I have just given you a representative image of the same. One is soft tissue sarcoma, the other is Kaposi's sarcoma. Like you can see, they are very different from each other. There's no link between those two, but these are included under the same umbrella term because they have arisen from soft tissues within the body. Osteosarcoma among these is the most common cancer of the bone. There are other osteo simply means bone itself, and sarcoma of course is cancer of the bone. I knew somebody with osteosarcoma as well, a close relative, and the worst part of diseases like these is that they have arisen from soft tissues that you very rarely will be able to excise from your body. As a result, the expected recovery, the expected outcome is extremely poor. And in most cases, patients are not able to survive beyond 2, 3 years, depending upon how serious the disease is or how severe the disease is. But apart from osteosarcoma, there are other common types of soft tissue sarcoma as well, like leiomyosarcoma, Kaposi sarcoma, which I have just represented here. Kaposi's can happen throughout the body. This I just showed the nose because that's you can very bluntly see what it is looking like. Malignant fibrous histiocytoma, liposarcoma, dermatofibrosarcoma, protuberance, etc. So basically, all of these terms, the terminology before sarcoma basically indicates the tissue from which it has arisen. So I want you to go back and look at it because you will not very commonly not hear about these sort of cancers. It's always breast cancer, liver cancer. So these are more commonly heard of, but all of these can also arise. And more often than not, there is some genetic background to it as well. When I say genetic background, it basically means that, say, for example, somebody has a history of cancer in their family. So there is a susceptibility of that person. Susceptibility as in they are more there's a slightly higher chance of them actually getting the disease. In some cases, there is some genetic defect, like, for example, you might have heard about BRCA1, BRCA1. BRCA1, BRCA2 mutations. These were actually popularized, not popularized, but were brought to light by a lot of famous people as well, whereby they explained that because they carried a certain genetic mutation from their parents, they will, like, there's a 90% chance that they will develop cancer eventually. So that is one train of thought whereby you carry a specific genetic mutation. Another train of thought is that if somebody has history throughout their family, there is a propensity or a probability that they will be more prone to getting the disease than somebody else. So in those cases, people like that, they undergo screening more regularly to ensure that they're healthy, and God forbid, in some case, they do actually have the disease, then diagnosis occurs as soon as possible, and therefore treatment regimens can be started quickly. That is the ultimate solution. You cannot, in except in a few cases, you cannot prevent cancer all the time, but you just have to be quick, smart, and efficient about removing it and treating it, and before it can actually spread throughout the body. So again, coming back to the presentation, um, we talked about sarcomas, and here you can see some other examples of all throughout the body whereby sarcoma can spread and what are its different subtypes. So angiosarcoma is whereby malignant neoplasm. Neoplasm is a tumor. Uh, uh, a tumor of the vessel walls. So angio is usually used for blood vessels. We will be discussing it pretty soon when we talk about hallmarks. I hope I'm not running out of time. No. So angiosarcoma, then comes osteosarcoma, bone tumors, Ewing sarcoma within the bone. I want you to read up about Ewing sarcoma also a little bit. I've not brought it here, but you can read about it. Um, chondrosarcoma, cartilage, cancer of the cartilage, GI stromal tumor or gastrointestinal stromal tumor within the GI tract when cancers occur. Liposarcoma is for fat cells, fibrosarcoma for fibrous connective tissue. Hemangioendothelioma is for vascular neoplasms, which vascular neoplasms mean within the blood vessels. So just unimaginable how far sarcomas can go. But yeah, any tissue, any soft tissue within the body, if it eventually forms a neoplasm or it forms a tumor, that will be considered to be a sarcoma. So yeah, this was the second class or second subtype. The next subtype is something you might have heard of a lot more commonly, which is leukemia. So cancers beginning in the blood-forming tissue of the bone marrow, they are called as leukemias. What you need to keep in mind is that these do not actually form solid tumors, like a mass of cells are not formed. So that actually has both pros and cons. Um, what is the obvious con? It's more difficult to eliminate directly. Like you can't just perform surgery and remove a mass of cells. It's within your blood, it's circulating. So what happens there is large numbers of abnormal white blood cells. I hope you have background about RBCs and WBCs. If not, just basic idea is that there are Apart within your blood, multiple types of cells are present. A major subtype of that are WBCs or white blood cells. Within white blood cells also, you have several subtypes. You have platelets also, you have macrophages also, and you have eosinophils, basophils, neutrophils, all of these as well. And what happens in case of leukemia is that WBCs are formed. A, they are formed, they are increasing in number. B, they are abnormal. They are not working the way a normal white blood cell is supposed to work. Because logically, if you think about it, if WBCs are supposed to, be the protectors of your body, if about T cells or B cells which are producing antibodies, all of them are supposed to form your immune system. But these white blood cells are they're not normal, they're abnormal. As a result, they are not A, not doing their function properly. B, what they're doing is they're using up the body's resources and they're compromising the health of all the other cells. What they also do is that they build up within the blood and the bone marrow and they crowd out the normal blood cells. As a result, there's a competition between those cells. So, like we just discussed, if there's an increase in the WBCs, why is that a problem? That is because the low level of normal blood cells within an individual's body can make it much harder for the body to get oxygen to its tissues, to control bleeding, or to fight infections. There are commonly four types of leukemia, which are grouped based on how quickly the disease gets worse, whether it is acute or it is chronic, and on the type of blood cell that the cancer starts in. So there is a lymphoid lineage, there is a myeloid lineage. If you've studied basic immunology, you might have studied this already, that there are two subtypes, and based on what type of lineage it arises from, different nomenclatures are used. And just to understand it very basically, acute forms of leukemia occurs very quickly. So somebody who say on day X is diagnosed with acute lymphoid leukemia, they would not be able to make it for a very long time. And in some cases, children, they have chronic forms of leukemia from their very childhood. So in those patients, long-term treatment is often done. Bone marrow transplants are carried out, etc. So depending upon the disease severity, different strategies are taken care of. But yeah, apart from that, apart from the oxygen factor, what you also need to understand is that bleeding control or basically clot formation is very significantly compromised in such people, and therefore that makes um, like the most basic cut also becomes very severe. If you've studied about hemophilia, it's a different sort of disease. It's a genetic disease, but in those cases also patients, they bleed out very excessively and their bleeding cannot be controlled. So that becomes a problem as well. So that was about leukemia. Apart from that, there is also lymphoma. Lymphoma, if you are not already familiar with it, read up a little bit about the lymph nodes within the body. That's a very huge topic, actually, so I can't go into much detail. Um, if anybody is interested in learning a little bit about immunology, then I have some lectures uploaded on YouTube as part of when I was a teaching assistant before this. So there are some recorded sessions available. You can read up on that. You can refer to Kubi Immunology. It is the best book for learning about the immune system. So you can read up from there. But basically, lymph is the fluid which is present within your lymph nodes, which carries your immune cells from the primary organs to all of the lymph nodes throughout the body, and that actually helps you fight infection. So, T cells and B cells, macrophages, all of them, they are carried via the lymph to all of these different organs, and it is necessary and extremely crucial for normal, healthy survival of a person. Now, when lymphoma occurs, what is happening in that case is that cancer is arising in the lymphocytes. When I said leukemia previously, that was only about the WBCs of the body. When I talk about lymphoma, that is occurring only within the lymphoid lineage cells, and that occurs within the T cells and the B cells. In this case, abnormal lymphocytes, they build up in the lymph nodes and lymph vessels as well as other types of other organs within the body. Two main types of lymphoma are most commonly understood: Hodgkin's lymphoma and non-Hodgkin's lymphoma. In Hodgkin's, people with this disease, they have abnormal lymphocytes, which are called as Reed-Sternberg cells. That's just the um, like the diagnostic criteria for confirming that a patient has Hodgkin's lymphoma. And these cells usually form from B cells. Non-Hodgkin's is a large group of cancer. It includes a large group of cancers that start in the lymphocytes and can form either from B or T cells. So again, I gave you a lot of information. Let's sum it up. We talked about carcinoma, adenocarcinoma among that, basal cell carcinoma, squamous cell carcinoma, and the fourth one was transitional cell carcinoma. We move to the next subcategory. We talked about sarcoma. Sarcoma arises from the connective tissue among or soft tissues within the body. Among those, we learned about some different subtypes. We learned about osteosarcoma of the bone, chondrosarcoma, etc., etc. I give you all of those different names. Next, we came to leukemia. Leukemia is majorly because there are four types based on how acute or how chronic it is. And finally, we learned about lymphoma as well, whereby lymphocytes, which are the T cells and B cells, they increase rapidly in number. And majorly, they are of two types. There is Hodgkin's and non-Hodgkin's lymphoma. So that sums up what we have discussed till now. If there's any doubt, please let me know. I'll just pause for a minute at this point before we move ahead. I might be going fast, so just please let me know. I'll slow down the pace if needed, or if I need to speed up, let me know that as well.
Ma'am, is lymphoma is a subtype of leukemia?
Uh, no. Lymphoma and leukemia are like you can think of them as blood cancers in general, but lymphoma and leukemia, they are occurring in different fluids are different. When you talk about leukemia, it is within the blood. When you talk about lymphoma, it arises from the lymph, or it arises from the lymphoid organs. Then it can spread in other places. It can invade the tissue and then eventually access the blood. Origins are different. Treatments are also different. So all of the subclassification, it might be overlapping, because when we talk about WBCs, then you think of T cells and B cells also coming close to it. But no, the source of it is slightly different. Okay. Now, this will be the last slide on subtypes. Then we'll move on to, yeah, Ankit, you were saying something?
No, ma'am.
So finally, this will just be a quick summary. Apart from what we have already discussed, within the blood cancers, there's another smaller subtype as well, which is of myeloma. So multiple myeloma is a cancer that begins in the plasma cells. The abnormal plasma cells, also called as myeloma cells, build up in the bone marrow, and they form tumors in bones all throughout the body. And it's also called as plasma cell myeloma or Caller's disease. So here you can see just a schematic representation. So this is normal blood. Within the blood, you can see that these WBCs, they are taking over. So RBCs, like think of it in this way. Think of any blood vessel, the space or it's not actually space, it's the rate at which blood cells can diffuse through a blood vessel. So that is limited, right? It cannot expand. Um, which brings me to another disease. You might have studied it at some point of time, atherosclerosis, arteriosclerosis, all of these things you might have studied, where along the lining of a blood vessel, when somebody has very high HDL cholesterol levels, then there is deposition of cholesterol along the walls. So space becomes limited. So number of RBCs that can pass through it, that becomes limited. The formation of clots occur, patients suffer, heart attacks, etc. All of that happens. This is different, but also very similar at the same time. That's because you think of it as the same limited space. It's just that instead of the space crunching, the number of cells are increasing. So in this case, RBCs are not able to compete with the amount of WBCs that have actually increased. And as a result of that, I'm just explaining the origin of the disease to you. The consequence of that disease occurring, they are much worse. Like for example, I met somebody who had leukemia and I saw that their eyes were completely yellow. So there's a the starting of the disease occurs at one place, but what happens is that when it is within the immune cells, when it can be detected by the body starts reacting. So people suffer from other accessory diseases as well, and that is how diagnosis can also happen. So in leukemia, jaundice or yellowing of the eyes, bile levels increasing, all of that also occurs very frequently. When you look at lymphoma, you can see that these healthy cells, they look abnormal. They are growing in an abnormal manner, and they are very enriched with, not enriched, but the increase in lymphocytes is much, much higher. Third is myeloma. So these are white blood cells like B cells, plasma cell, and multiple myeloma as well. To answer Ankit's question, maybe I'll revise it once more. I think they might be overlapping as well. Conceptually, what I remember is that leukemia and lymphomas are grouped separately, but I will check it once to be completely sure. I'll just get back to you in the next class. But yeah, for myelomas, you can see that these multiple myeloma cell releases some sort of M proteins, and there's a huge increase in the plasma cell number, and they outcompete other cells of the blood as well. Finally, melanoma is a cancer that begins in cells that become melanocytes, which are specialized cells making melanin within the skin surface, the pigment which gives skin its color. Most melanomas form on the skin, but they can also form in other pigmented tissues, such as the eyes. I've not gone into much detail about it. Because it's not something we very abundantly see, its frequency is much less. And because if we go into the biology of each subtype of cancer, this will be a never-ending course. So we are trying to keep it more informative while being more relevant to basic understanding of cancer biology and then catching up with advanced concepts. Other categories into which tumors are sometimes divided include neuroectodermal tumors, medulloblastomas, which arise from central and peripheral nervous systems, small cell lung carcinomas or SCLCs, and germ cell tumors. So these are, as you can obviously guess, they are much, much less prevalent. In a lot of cases, they arise in infants, and in such cases, either infants have to undergo very aggressive treatment strategies, or in most cases, they actually do not make it for very long. So these are all the different cancer subtypes. Now, moving to the more new concept that, or I'm guessing is a concept that is relatively more new to you. So we are talking about the hallmarks of cancer. So if you remember, I had introduced these two scientists, Professor Douglas Hanahan and Professor Robert Weinberg, who have given us these concepts. So they have actually discussed the question we addressed previously, which is about how cancer cells undergo transformation. So these are the three articles that I mentioned, Hanahan and Weinberg, Hallmarks of Cancer in Cell, in 2000, in 2011, and 2022. Why I have given so much weightage to this is because if you, I'm not sure how familiar you are with reading research articles, but if you want to eventually get into academia, it's a great idea to start reading at least review articles. These are all reviews. They give you a lot of information in a condensed manner, and you'll be you'll be able to see the evolution that has happened in the last 20 years or so. So in the first article, they had proposed a set of a definitive set of hallmarks. They then modified it further in Hallmarks Next Generation. They added a few more characteristics, few more concepts. And finally, in the third part, which was only published by Hanahan 2 years ago, 3 years ago, he has discussed new dimensions in it, and he has brought up some new concepts known as emerging hallmarks, and also known emerging hallmarks and enabling characteristics, both of these. I'll briefly mention it later. So overall, in these review articles, they have characterized a set of hallmarks which are defined or which are established as the functional capabilities acquired by human cells as they progress from normalcy to cancerous states. So what are they? They are capabilities or functional attributes. Like, for example, a cell was not able to do X function before. It has acquired the ability to do function X, and now it is um, on the road or on the path to become cancerous. And this includes, this is not just one, there are many, many hallmarks. I'll be mentioning only the core hallmarks today. Um, because this, as you can understand, 3 review articles is a lot of information. I have tried to keep it as relevant and as crisp as possible so that it's more, it's interesting and you can understand it better. You can always go to the articles and refer to it, or you can come back with doubts and we can have a discussion as well. So this is how hallmarks are represented. So this is actually taken from the last article, Cancer Discovery 2022. So these are the hallmarks that have been defined over time. Today, I'll be discussing only the first 6 hallmarks, the core hallmarks that were proposed in the first article. But let us at least understand or get familiar with all of the different names. So these are just symbolic representations of the hallmarks. The first one that was understood was sustained proliferative signaling. We'll be reading about it, don't worry. Next was evading growth suppressors, avoiding immune destruction, enabling replicative immortality, tumor promoting inflammation, activating invasion and metastasis, inducing or accessing vasculature, genome instability and mutations, resisting cell death, and deregulating cell metabolism. What does this mean? Overall, like I just mentioned, these are all the functional capabilities that a normal cell, when it acquires, it can become cancerous. Now, one question that might be coming to your mind is that does a cell need to have all these capabilities? One is good enough, combinations are needed. You don't know. It depends upon the cell, which of these capabilities it can acquire. Technically speaking, one hallmark is usually not enough, but in a lot of cases it might be enough. For example, think about genome instability and mutation. Genome mutation or genetic mutation is something we very commonly hear about it, that DNA has mutation and a patient suffers from cancer. But it is not just that. Having that mutation is not enough. A lot of other checkpoints and a lot of other signaling programs within the cell have to go awry, have to be disrupted for the cell to actually become cancerous. So more often than not, a number of hallmarks, say 2 or 3, a combination of hallmarks are usually found to be present within a cell that has become cancerous. Among these, the core hallmarks are these: sustained proliferative signaling, evasion of growth suppressors, enabling replicative immortality, activating invasion and metastasis, resisting cell death, and angiogenesis, or basically inducing vasculature. These are the 6 we'll be discussing today. Apart from that, you can read about the rest of them, especially genome instability and mutation is very, very relevant, but it was not discovered, integrated as a hallmark much later, so I've not included it today. But basically, it means that instability of the genome. Now, if this is a concept you want me to discuss, let me know. Maybe we can incorporate it in one of the upcoming classes. But genome instability is it's a crucial concept. It's something very, very commonly seen in cancers, and it is something which has been identified even better after we have become familiar with NGS technologies. So that's when we know it a lot better. Apart from that, deregulating cellular metabolism, it basically means deregulating is, as you can obviously understand, disturbed regulation or dysregulation is what happens within a cancer cell. So normal cell metabolism is completely lost. Cells start metabolizing nutrients very rapidly. Read up on Warburg effect, WARBURG. It is very, it's relevant, interesting, and very crucial to your understanding of cancer biology. So I want you to read up on it. We'll discuss it in the next class. So deregulating cellular metabolism. Apart from that, avoiding immune destruction, which means that cancer cells, they don't just have to become cancerous, they have to avoid the immune system of the body, and that helps them acquire the cancerous state much better and survive after becoming cancerous as well. Tumor promoting inflammation is a concept that might be slightly difficult for you to understand at this moment. But basically, think of it in this way. Inflammation is usually a strategy to remove something undesirable from the body. But in some cases, this immune response or this inflammation is actually helpful and is actually tumor promoting in nature, and that enables a tumor to survive much better. I'll keep it at that. It is a a little twisted concept. So we'll just leave it at that for now. We'll focus on the hallmarks for today. But apart from that, I also want you to understand these further concepts as well. So you can see that this initial table that was proposed has integrated some new concepts as well. So this actually first schema that you are seeing, first figure that you are seeing was described or was defined in the second hallmark article, which is called Hallmarks Next Generation. But then in the third article, Hanahan has proposed that these further categories should also be included. And so these have been defined as emerging hallmarks. What you see in blue is considered as an emerging hallmark, and what you see in red is considered as an enabling characteristic. So I have mentioned this in the questions for this class, thinker questions, or just a little bit of homework for you to do for your own understanding. We'll discuss it either in the next or the following class after that. But I want you to learn the definitions of emerging hallmarks and how is it different from a normal hallmark, and same for enabling characteristics as well. Just it's nothing very serious, but it'll teach you how to figure this out. You just need to go to this article. You'll find both definitions there very clearly. But yeah, I want you to go through that article once. So emerging hallmarks have been unlocking phenotypic plasticity and senescent cells, whereas enabling characteristics are non-mutational epigenetic reprogramming and polymorphic microbiomes. So again, slightly advanced concepts, non-mutational epigenetic reprogramming, we'll leave it be for now. Maybe we'll come back to it a little later when we talk about diagnostic techniques in the upcoming classes. Maybe we'll discuss it then. So for now, let's look at the hallmarks. So the first hallmark, the core hallmark that I talked about, was sustained proliferative signaling. What does it mean? So, okay, before we go into, I hope the diagram doesn't scare you very much. Let's just discuss it first directly. We have talked about proliferation before us as well, right? So proliferation and cell division, very commonly they're interchangeably used, but conceptually what you need to understand is that cell division is a physiological process which occurs inside a cell. So a cell, one cell, it expands, the nucleus divides, that undergoes prophase, metaphase, anaphase, telophase, forms two daughter cells, and that is the process of cell division, which is normal, necessary. Next come proliferation. Proliferation is analogous and yet different. There's a reason these two terms are used separately in separate cases. When we talk about cancer cell proliferation, their rates of proliferation are expected to be normal, much higher than normal, and it is supposed to be dysregulated or unregulated. So this proliferation is controlled. While we say uncontrolled cell proliferation is occurring, you have to understand that something is occurring inside the cell that they are now actually able to proliferate. So more often than not, there are multiple signaling pathways which are activated that sustain that proliferation, that sustain that level of cells continuously dividing, increasing in number, and no checkpoints being in place. So that is usually controlled by signaling pathways. We will be discussing signaling pathways in our next class. That is actually the topic to be covered for week 2. There are innumerable signaling pathways that exist in a normal cell. Not innumerable, but like a lot of them. And one important thing to keep in mind is that there is crosstalk between pathways. So there's pathway A, pathway B. You might think that, oh, when there is a condition, only pathway A should operate and B should be shut off. That's not actually how it works. It's a cell. It's a living, breathing organism, part of an organism, and therefore crosstalks occur. Altogether, multiple pathways altogether help in sustaining proliferative signaling and therefore enable the cell to become cancerous. What I have shown in this example is just a representation of some of the parallel pathways that help in, which aid cell proliferation and which aid cell survival. So here you can see, I'm just giving this as an example, you can see EGF or epidermal growth factor, which is bound to the receptor on the surface, and downstream pathway, which is known as the MAP kinase pathway, is activated, and that is the physiological process which occurs. So basically it's a ligand driven control, which is placed within a cell under normal circumstances. So this is EGF, which binds, and only then the pathway is switched on. Apart from that, there is also a JAK-STAT pathway. It's just given here as an example. So don't worry if you are unfamiliar with any of this. We'll be discussing it on Monday. So here a cytokine comes and binds to the receptor, which is a receptor tyrosine kinase. And then the JAK-STAT signaling pathway helps in normal cell proliferation and cell survival. This is what goes wrong in cancer. The first one you see is that there is a mutation in this receptor. The first receptor that we saw here carries a mutation. This is how you read mutations. T790. What does it mean? So T stands for threonine, M stands for methionine, L is for leucine, R is for arginine. These are all of the different amino acids. So threonine at position 790 has been mutated into methionine. Leucine at position 858 has been mutated into arginine. So what happens? This single base mutation might be a single base mutation. Oh, sorry. Yeah. This single mutation is capable of completely disrupting this signaling pathway within the cell. As you can see, now what happens is that within the receptor, this ligand binding domain is no longer necessary. The transactivation domain or the cytoplasmic domain, the part which is inside the cell, that is constantly switched on. This is just a simple mutation, as a result of which the receptor is constantly switched on and this pathway is constantly active. This is in contrast to the regulation. So there, what was being maintained was there was a control. Think of it as if there is some regulation. Somebody is coming into your door, only then you are making tea. In contrast, you're constantly making tea even though there is nothing needed. What you're doing is you're using up your resources. And what will happen unnecessarily then is that you're exhausting the cell, and then the cell is no longer able to function normally. This was just a vague example, but think of it in terms of cell division. That means a cell will constantly be active, and this sort of activation is called RTK-driven or receptor tyrosine kinase-driven oncogenic pathway. This was just an example. But yeah, this is another example of a mutation where an EGFR mutation can be targeted by multiple types of drugs. So a drug might inhibit this domain, a drug might inhibit this domain, or might inhibit the activation pathway. All of these are just basic strategies that can occur. So here I talked about a mutation in the receptor. There can also be a mutation within the downstream pathway genes. So you can see if you are not familiar with the genes of the pathway, don't worry. Just look at their names for now. We'll go into details about this in the next class. RAS, which is the first like the signal amplifier in this case, or signal transducer in this case, RAS is undergoing a mutation. So under normal circumstances, RAS will not be switched on unless and until EGFR tells it that this pathway needs to be switched on. However, when RAS carries a mutation in G12, G13, or Q61, which is glycine or glutamine, which is a X means it is a it can have any mutation for that matter, or it is carrying a termination, which means it is a short protein. When mutations are present in this site, then what it can do is it can constantly switch on this pathway, even when the receptor is not required. So there is no stimulus from the outside which is coming in. It is simply an intracellular control. Nobody else is controlling the cell. Now the cell has switched on this pathway and it is constantly going to keep on dividing without any regulation or without any control. So this was one example. There can also be mutation in the downstream pathways like BRAF, V600E. This is something we have extensively studied in prostate cancer as well. So these are just some examples of oncogenic mutations which sustain proliferative signaling within a cancer cell. So oncogenic somatic mutations in such key survival pathway genes drives the sustained activation of downstream genes. Furthermore, while I have not mentioned it here, but there are some negative feedback mechanisms also which attenuate proliferative signaling. So just if I explain it in a simplified manner, basically think of it in this way. Let's go back to the example of making tea. You have been taught that when there's a guest in your house, you're supposed to make tea. Now there is supposed to be another control, which is going to be a negative feedback control, which means that once this pathway has been switched on, that there's a guest, you're making tea, but you will not keep on making tea indefinitely. There has to be a feedback when the guests tell you, no, that's enough, and that's when you stop. So there has to be a feedback which is operational within the cell to keep a control on how much proliferation can actually occur. When this negative feedback is also lost, the same consequence can also be faced. So when the guests do not tell you no, you keep on making tea, and that is also a waste of resources. Similar to that, a cell will keep on proliferating despite the fact that there is no external stimulus, but a cell can also keep on proliferating when there is no feedback, and therefore both of them can actually lead to continuous proliferation, and which is sustained by cancer cells. And it also triggers cellular senescence. We'll briefly discuss it in the upcoming slides, but just hold off on it for now. Let me know if there is any doubt within the first hallmark before I move ahead. Please unmute and discuss anything you want to be discussed, anything. I will study and come back to you if I don't have the answer for it right now. Please go ahead and ask. Okay. If not, you can ask at any later point as well. But moving on, we'll look at the second hallmark of cancer, which is the evasion of growth suppressors. So basically, what you see here is a schematic representation. Conceptually, let us understand something. So within the cell, like I just said, there is a control which is maintained by negative feedback mechanisms. So feedback mechanisms are one group responsible for this purpose. There's another group which are growth suppressors, which means that it simply says, no, you're not going to proliferate any further. So growth suppressors under normal circumstances, physiologically within a cell, are extremely crucial for maintaining that control. In a cancer cell, the regulation of both of these is completely lost. If I just quickly use two terminologies. Most of you might be familiar with it. One is oncogene, another is a tumor suppressor. Oncogene is something which allows oncogenic mutations, which allows cells to proliferate rapidly, haphazardly, keep on dividing. That is under the first category, sustained proliferative signaling. Tumor suppressive genes, under normal circumstances, ensure that a cell does not become cancerous and they maintain the sanctity of a cell. When tumor suppressor genes are also mutated, then that is also going to lead to cancer. This I just gave as two examples because the hallmark is more generic in nature. It is for covering the entire idea of cancer biology. But yeah, these are terminologies we are more familiar with. That's why I just thought I'll mention it. Now, when we talk about evading growth suppressors, evasion can be of two types of things, AGS or TSP. AGS stands for anti-growth signaling, or TSP is tumor suppressor pathway. When both of these are evaded, there are two possible mechanisms by which it occurs. It can either be in a genetic manner or an epigenetic manner. Epigenetic basically means, literally, it means above the genome. So control or regulation of the genome is covered under epigenetics. Epigenetics, if you have already studied it, basically involves modifications of your DNA or of the protein onto which DNA is bound. So there's histone. Histone is just, think of it as any protein X. So this is a histone protein, a histone octamer around which DNA is bound. So that is how DNA is maintained or contained within the cell. So modifications on the DNA or on the histone itself, both of them are included under epigenetic modifications. So these are known to lead to several downstream mechanisms. I'm not going into the names of the pathways. You can look at it for your reference, but basically RBP53, they are tumor suppressors, P10, Hippo, ARID, all of these, they are tumor suppressive in nature. And there can be mutations in all of these pathways, or there can be epigenetic modifications of each of these genes, all of which are eventually leading to the fact that they are helping cells evade growth suppressors. What you see at the bottom is different strategies which can be used to restore the function of these proteins. So think of them as security guards, as sentinels, which ensure the harmony of the cell, and that harmony is lost. So different strategies for restoration have actually been discussed here. So that is what you see here. Just a second. Yeah. So somatic mutations in these key tumor suppressor genes blocks the feedback loop, which is necessary for regulated cell proliferation. Activation of the EMT program also triggers invasion and metastasis. And finally, activation of autophagy. All of this help in evasion of growth suppressors. Now, a question we will answer here eventually is, what is EMT? We'll look at it in a few slides, don't worry. Autophagy is something that I want you to go back. I will touch upon it, but I want you to go back and read about it a little bit. Some things I'm just leaving as thinker questions for you. You'll have 3-4 days to go through it, and you'll get into the habit of studying some, or just at least Googling a few things for yourself as well. The third hallmark is resisting cell death. If at any point you find these different attributes to be overlapping, it's completely natural. What you need to understand is that they are controlled or they are regulated by very, very different pathways which are downstream of it. These pathways interact with one another. That's why it looks overlapping to you, but no, the regulation is separate. So don't worry about that at all. Talking about cell death. Now we talked about the fact that cell division is supposed to occur in this manner, and these control mechanisms are put in place. What you also need to understand is that cell death is just as important and just as necessary to ensure organismal health, because that will control unnecessary proliferation and unnecessary consumption of resources. So cancer cells figure out different ways to resist the process of cell death. Let us look at some common methods by which cell death is regulated. Autophagy, which is something I'm very briefly touching upon. Autophagy is a cellular degradation pathway which helps for the clearance of damaged or superfluous proteins and organelles. The recycling of these intracellular constituents also serves as an alternative energy source during periods of metabolic stress to maintain homeostasis and viability. In tumor cells with defects in apoptosis, autophagy allows for prolonged survival. What does it basically mean? If I put it into one of those catchy taglines, autophagy is basically a process where a cell eats itself. So why does it do that? That's because think of it in this way, that the cell looks at the greater good. So it chooses to sacrifice itself so that other cells can consume its nutrients and then survive. Instead of all of the cells surviving horribly or maybe not surviving, some cells die, and that allows other cells to utilize the resources from the first cell and therefore survive. So it's a degradation pathway. So it clears out damaged proteins and damaged organelles and damaged parts of those cells, and they are consumed to keep other cells healthy. How is autophagy relevant in cancer is something you must look at. There are two aspects to it as well. I've mentioned it in the thinker questions. We'll come to it very soon. The other strategy for cell death is necrosis. Now, what is necrosis? It is an uncontrolled form of cell death that results in the swelling of the cell organelles, plasma membrane ruptures, and eventually the cell lysis. And intracellular contents are spilled into the surrounding tissue, leading to tissue damage. What I want you to definitely read about, if you're not familiar with it, is the process of apoptosis. Apoptosis is otherwise known as programmed cell death. That is the definite pathway which is normally followed, should be followed, and should be under extreme control. That is cell death. And programmed cell death has two different major pathways, the intrinsic and the extrinsic pathways, which are followed for apoptosis. There's a heavy dependence upon the mitochondria for this purpose, release of cytochrome C, etc. I'm not going into details of this. Apoptosis is a chapter by itself. It can take up 2-3 classes just by itself. So I'm not going into detail about that. I think you might know. But this is just an image to compare between those three. If you want a discussion on apoptosis, please let me know. I'll try and incorporate these concepts eventually. So this is a normal cell. Compared to that, if you look at necrosis, the cell has burst, it has lysed, burst, and released everything that was inside into the surrounding environment. It is not a controlled process. It is damaging, and you can see that the cell integrity is completely gone by. Apoptosis, on the other hand, leads to swelling, but then eventually the cell will shrink. Swelling, as in the cell will um, in the preparatory phase, it will swell up a little bit, but it will not burst. Instead, several pathways will come into place to eventually form autophagosomes, and then the cell will die in a peaceful manner, and the cell's resources can be used by other cells as well in that case. And there are multiple mechanisms for evasion of apoptosis. In cancer, the most predominant mechanism is increase in BCL2 or BACs, which are anti-apoptotic proteins. And these are all sub-steps. I'm not going into details about them. You have to be more familiar with the technique. But yeah, there are multiple strategies by which apoptosis or programmed cell death is evaded or is resisted or is avoided by cancer cells. Therefore, it has been included as a hallmark of cancer. Uh, the next hallmark is enabling replicative immortality. What does it mean? It means something to understand that you must first understand this concept. Are cancer cells immortal? There was a concept that was proposed by Leonard Hayflick, the scientist you see here, whereby around 65 years ago, Leonard Hayflick discovered that in culture, what is the meaning of in culture? It means that cells which you maintain, which you propagate, increase in number, and keep on passaging inside lab conditions, they are known as cultured human cells. So Leonard Hayflick, he suggested or he identified that normal human cells, when they are in culture, they have very limited capacity to divide. So here you see different phases. So the first 50 days, they are in phase 1, they are doubling in a good pace, and phase 2 also they are doubling. But beyond a point, after a certain number of passages, cells attain senescence, which means that cells are no longer actually dividing. So this is the ability of normal cells. Keep it in mind. So the cells, they attain senescence. This is known as Hayflick's limit because he gave the concept. This is the nomenclature that was followed. But for cancer cells, they actually lose this ability and they are able to divide indefinitely and they are able to attain replicative immortality. So what is the reason that they are actually, what is the reason we are at all worried about it is because there are two barriers to normal cell proliferation. One is senescence and the other is apoptosis. We discussed apoptosis. We talked about the fact that cancer cells are able to avoid the methods that are used normally for regulating cell death, and they're able to evade apoptosis by all of those different strategies, which I showed. On the other hand, the second barrier to cell proliferation is attaining senescence. So that senescence is also lost. What is senescence? Senescence by itself is a non-proliferative but viable cell state, which means that the cell is alive, it is proper, it is, when I say healthy, I mean it is functional, but it is not dividing. It is in an undividing but healthy state. So cells, normal cells attain senescence. However, cancer cells fail to do so. There are multiple hypotheses about why exactly that happens, but a major reason is because of the overexpression of telomerase, which is a huge, huge driver for enabling replicative immortality. What is telomerase now? If you have studied DNA replication at any point of time in your earlier classes, earlier lectures, basically the human genome, it has it is a linear genome, which means it is a straight genome. Bacteria, they have circular genomes. Think of it as a closed rubber band. That is how their genome looks. And think of our genome as a thread. So it has ends while bacterial genome does not have ends. So the ends of our DNA, they actually every time that DNA divides, what actually normally should happen is that the ends of the DNA do not get replicated. This is called the end replication problem. I'm not going into so much detail about it. You might have studied it. If not, then we can discuss it. But that's the most one of the most basic concepts you discuss in eukaryotic or human DNA replication. So the end replication problem is such that in the lagging strand, the last part of the DNA is lost. So in normal cells, what would normally happen is that every time the cell undergoes a round of division, some part would keep on getting deducted. So the ends of the genome would keep on getting smaller, 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 smaller. Eventually, what happens is that the cells are no longer very capable of having all of those, they do not have all of the necessary components for them to keep on dividing rapidly. And what they eventually do is they attain senescence. When cells express telomerase, which is expressed in normal cells as well, what they are able to do is telomerase is an enzyme. What does it do? It goes and takes care of these ends of the genome by adding the telomeres at the telomeres, and it maintains the length of the genome. However, telomerase function is only so much that it can actually function, and over the time, over like beyond 30, 35 years of age, what happens is gradually telomerase function is not able to outcompete the amount of broken DNA, not broken DNA, but shortened DNA that is there. Therefore, over time, what we start seeing are symptoms of aging, compromised immunity, etc. So this happens physiologically. In cancer cells, the overexpression of telomerase is present. As a result, they are able to repair the ends of the DNA and they're able to proliferate super fast. And therefore, that enables replicative immortality, which means they are immortal when it comes to replication, and they're able to keep on dividing without attaining senescence. So these are the two strategies that have been taken care of by all cancer cells. The second last hallmark we'll be discussing today is induction of angiogenesis. What is angiogenesis? Literally, it means the generation of blood vessels. So angiogenesis is a process in which new blood vessels develop from existing capillaries and eventually they form a complete, regular, mature vascular network. What does this mean? Simply put, there are capillaries within the body, there are blood vessels within the body. From there, new blood vessels are forming, and what they eventually form is a network. During tumor progression, an angiogenic switch occurs, which is almost always activated, and it remains on. What does that do? It causes normally quiescent vasculature or normally functioning vasculature to keep on sprouting new blood vessels. You have to take care of the words which are used here. Sprouting blood vessels. What does it mean? In a normal manner, in a normal cell, under physiological condition, if there is one blood vessel, from there it will branch out into one or two, and it will keep on expanding as per requirement. When we talk about a cancerous cell and angiogenesis for a tumor cell, there it just keeps on branching rapidly and haphazardly, and it grows in any way without any control, and therefore the word sprouting is used here. Why is that necessary? It helps in sustaining the expanding neoplastic growths or expanding tumor growths. This is extremely important to understand that the tumor vasculature, while it is increasing and the tumor vasculature is forming everywhere and it is providing so much blood supply and all of that is happening. The problem lies in the fact that this vasculature lacks any hierarchy. Hierarchy means that from a bigger blood vessel, there is branching into smaller blood vessels, which are branching into capillaries and which are again connecting into another blood vessel and eventually joining into another blood vessel. That organization is completely gone. So that hierarchy is absent. And what does it do? Instead, it becomes disordered, it becomes tortuous, leaky, and therefore that vasculature is completely wrong. So while it provides oxygen and nutrients to the cancer tissue, it completely disrupts the normal vasculature of a system and therefore health is compromised. So here you can just see an example of what happens. So tumor cells which are close to a blood vessel, they secrete certain factors like VEGF, which is vascular endothelial growth factor. What does it do? This normal main blood vessel, which has normally branched into just one or two sub branches, what this secretion of VEGF does is that it increases the blood vessels movement towards the tumor, and it wraps around the tumor. This actually is not a GIF, but think of it as this. If this is a tumor, the vasculature surrounds it completely. Why is this necessary? Logically, think about it in this way. If you have a 3D structure, the center part of it will not receive any oxygen if you don't have enough blood supply. So that also needs to be connected to blood supply, and therefore it completely engulfs the tumor. For a normal tissue, you have vasculature which is present throughout that organ. But for a tumor, because it has not formed in an organized manner, the center of it does not receive oxygen. That is why a very common phenomenon, which is often seen when we talk about cancer cells or tumors in particular, you might have heard of it, is the term hypoxia, hypoxic core. What does it mean? The center of a cancerous tumor lacks oxygen and therefore it is hypoxic. So cells within that region, they have to adapt accordingly. Again, these are very advanced concepts, not going into too much detail, but I just wanted to put these keywords in your head so that, if it is interesting to you, you can read about it. So basically, this is what happens is that there are angiogenic factors, example being VEGF, which are released or secreted by the tumor, which allows more and more blood vessel formation, or rather overgrowth of blood vessels on the tumor, which has increased blood supply. But what it does is it compromises blood supply in other parts of the body and therefore harms the normal physiological growth of cells. Finally, coming to the last hallmark that we'll be discussing for today, which is activating invasion and metastasis. So one very key attribute of cancer spreading throughout the body is the ability to, one, invade, two, metastasize. So I had discussed these at the very beginning of the class, if you remember. So we had talked about cells being able to breach the basement membrane and then being able to enter the tissue, moving into other sites within the body and forming secondary tumors known as metastases. All of this, while it does happen and while it is extremely serious and extremely linked to very poor prognosis, very poor outcomes, it does happen. And one major program or one major procedure which helps in activating and which helps in facilitating this process is known as EMT, otherwise known as epithelial mesenchymal transition. If you remember, I had asked this in one of the question boxes in the previous slide. So EMT or epithelial mesenchymal transition is a cellular program whereby cell-cell and cell extracellular matrix interactions are remodeled, which leads to the detachment of epithelial cells from each other and the underlying basement membrane, and a new transcriptional program is activated to promote the mesenchymal fate. In context of neoplasias, EMT confers on cancer cells increased tumor initiating and metastatic potential and a greater resistance to elimination by several therapeutic regimens. Too much jargon, very confusing, don't worry. Look at this diagram for reference. EMT is being shown here, MET is being shown here. Why so? Because it is usually a reversible process. This is your basement membrane that I had explained previously. Why is this necessary? Because this actually decides the polarity of cells. What does polarity mean? It means that epithelial cells under normal circumstances have an orientation, like north-south orientation. They have an orientation whereby the cell surface, which is close to the basement, is the basal edge of the cell, and the one which is at the top or facing away from the basal end is the apical cell. Right? You can understand apical basal polarity. It's extremely crucial that you remember this. This polarity is only maintained in epithelial cells which are healthy, normal. What you see over time, if you just look at the diagram overall, is that this polarity is completely lost. It is going through some transition and eventually this attains a sort of horizontal orientation where it has a front to back orientation instead of an apical basal polarity. What else do we see here? We see that in between cells and between the cell and basement membrane, you can see these little purple, let me zoom in. These little purple sort of connections which are present, right? So in between cells, there are something called as tight junctions and adherence junctions. These are, think of them as sort of locks like this, which are cell 1, cell 2 interacting via tight junctions and adherence junctions which are present. There are desmosomes and hemidesmosomes which are also present between cell and cell matrix or cell basement membrane interactions. They are basically, think of them as nut bolts basically, which are keeping all of these screwed together. in between cells and between the cell and membrane. All these interactions are present. What you see over time is that from the epithelial cell, as there is a gradual transition, you can see these hemidesmosomal connections which were present in epithelial cells are lost. Some of them are still maintained. Intercell or cell-cell adhesion is still maintained. However, over time, when cells have undergone this complete transition into mesenchymal conditions, all of it is lost. You can see there's no connection with basement membrane. Cells are not connected to each other. They have lost their polarity. There is generation of some actin stress fibers. Why is it necessary? Actin stress fibers basically think of it as dough, like, some atta, maida, all of these doughs. So basically you are stretching it, right? There are stress fibers which are present. So if you have a um if you have a lump which is just placed on your kitchen slab, it will not be able to go anywhere. If you push it a little bit, it will be able to move. Think of it as that movement. Therefore, actin stress fibers are present. So what has eventually happened is that cells which were epithelial in nature, they have undergone transition and now they have become mesenchymal in nature. Why is this necessary? When cells were localized within only one, the tumor cells were localized within only one location, then just being epithelial was okay. They were able to sustain. But when cells want to spread throughout the body, they have to acquire the ability to detach from the membrane they were adhered to. And now they must be able to move through blood because blood flux is also there. The entire push that is present within the blood, that is also there. So they have to endure it and they have to move through blood to other locations, and therefore they acquire this mesenchymal phenotype. As part of this process, lots of changes take place. These are just, eventually, if you want to come back to it, you'll be able to understand. But basically, from an epithelial cell to a mesenchymal cell, a lot of changes occur. Um, Overall, if I just mention it, say, for example, from E-cadherin, which is epithelial cadherin is a cell junction protein which is expressed on epithelial cells. That E-cadherin is lost. Instead, what comes in? N-cadherin comes in, which is mesenchymal form of cadherin. All of these changes occur. All these proteins, they go down. So the cell property changes, the cell morphology changes, and induction of mesenchymal state takes place. But what you must understand, this transition is necessary when a tumor cell is migrating, or a tumor mass is migrating from the primary site into blood. Once it has moved from blood and now it has acquired some new location, say for example, cells from a brain tumor have moved through blood and now they have localized into, say, lungs, for example. Now they have to settle into the lung. What happens then is they undergo the reverse process known as mesenchymal epithelial transition, or MET, whereby they again acquire this epithelial phenotype and then they localize within that tissue. They will be then able to extravasate. I will come to that terminology. Okay, this is actually the question. Wait, just give me a second. I'll show it to you. If you go back to this slide, you will see it here. Um, Under metastasis, we had multiple substeps present. So there was invasion, which means this basement tissue breaks. Intravasation, which means cells are entering into the blood vessel. Dissemination, which means from a tumor mass, they have dissociated and they have become individual cells. They have traveled through the blood. And now what happens? They will extravasate, which means they will move out of the blood vessel. After extravasation, they will colonize into the secondary site and they will form secondary metastasis. I explained this to you, but yeah, I want you to study this in more detail because it's part of your thinker questions. But basically, that is what happens, that from EMT, so think of it as a rigid structure becoming more relaxed and then becoming rigid again when it has to move into a new site. Finally, key takeaways from today's class. Cancer is a disease of uncontrolled proliferation by transformed cells subject to evolution by natural selection. There are several early stages of tumorigenesis, hyperplasia, dysplasia, etc., eventually which form carcinoma in situ and further progress to develop into cancer. Depending on the cell type and source of tumor origin, cancers can be classified into different categories. There are several key attributes acquired by cells as they transform into cancerous tumors. which are defined as the hallmarks of cancer. And what I also want you to read about, a few questions that I've already mentioned during the class itself. What is autophagy? Read about its pro-tumorigenic and anti-tumorigenic roles in cancer progression. What are the different substages of metastasis? I just mentioned it. I did not go into detail because I want you to read about it, and we will certainly discuss it. This has been a relatively silent class. I hope you feel a little more relaxed and we can be a little more conversational in the next class. So we'll discuss it in a little more detail. And I want you to read this, but if it is complicated, I think I'll mention it myself as well. The seed and soil hypothesis by Paget is something that will explain this concept to you in more detail, especially if you are looking forward to working in academia in cancer biology in the future. This is an almost short question you'll get asked in your interview, so it's always good to learn about it. And finally, what are emerging hallmarks and enabling characteristics? How are they different from the core hallmarks? I've already mentioned this. You'll find it in the cancer discovery article that I had cited. If at any point you do not have access to an article that you are interested in, like in a lot of cases, you'll find that some articles have restricted institutional access, or, for whatever reason, it is not, you have to download it or you have to pay for it or whatever, something like that. Just drop me an email. If I have access, I'll mail it to you directly. If not, I have multiple seniors who are, they have access to all of these articles, and I'll make sure you get it. So please let me know. I'm here to help you. I want you to be intrigued by cancer and I want you to completely love it. So yeah, that was the summary of today's class. Just now it is time for you to share whatever feedback, whatever questions, anything you want to discuss. Please go ahead and then we can wrap up the session for today. Please let me know.
Ma'am, if you don't mind, can you please go back to fifth slide? I have a doubt.
Fifth. Yeah, just a second. This one?
Yes, ma'am. In the second picture, it is written that there is low-grade dysplasia and then high-grade dysplasia. But after, like, the dysplasia turns into cancer. So when does the high-grade dysplasia turns into cancer?
Okay. So, okay, look at it in this way. This is a cross section of a tissue, right? Say, for example, think about this tissue by itself. What we can speculate, of course, it's for a pathologist to actually confirm, but what we can speculate is that cancer probably originated in somewhere, some location, some cell, which was more interior of the tissue, towards the cortex of the tissue. Once it had originated, what has happened is that carcinoma in situ formation has occurred more towards the core. However, cells which are at the surface, maybe they were not initially there were healthier cells at the surface. It's just a guess that I'm making with you as well. But what has happened is that the normal cells have been competed out in that region, and only dysplastic cells are present, which are abnormal and which have completely lost their organization. So within a tissue, same patient, same biopsy, same sample, you will find different gradings. You will find tissues which are in different stages. So what is done? How can you actually confirm it has cancer? If in a patient any one section is appears to be cancerous, then that patient will be considered to be suffering from cancer. It might just be that at that point of time, the location from which the biopsy has been captured, maybe that was not the tissue which was actually cancerous in nature. So then in that case, what is usually done is that multiple biopsies may be taken, or other tests might be done. For example, CTs might be done. PET imaging usually is not done in early stages, but CT might be done. And then it would be used to ensure, or, fMRI is done in a lot of cases if a patient has a lot of metastasis throughout the body and the whole scan lights up. So all of that can happen. So those are better ways of confirming. But if in the initial pathological study itself, the first biopsy itself, if somebody sees some tissue which looks from high grade to carcinoma-ish, then that patient will be suggested to undergo further staging. If somebody has low grade dysplasia, usually it is a there are two terminologies for it. One which is called watchful waiting, which means that that patient will be subjected to regular visits to the doctor to ensure that, okay, whatever cell mass that they have or whatever abnormalities they have in their cell, that is not becoming cancerous. Because in a lot of cases that also happens, that somebody might have a sort of benign tumor, but it has not really become cancerous. In that case, all that is done is that the patient is monitored for years. It can happen for like 5, 10 years also, that monitoring is done, and then the patient is completely healthy. But in case regular biopsies show that there is a gradual progression and cells are becoming dysplastic, and some of them are appearing to be sort of like carcinoma, then they will undergo more better profiling or more advanced techniques would be used, and then you call it cancer. Just pathology by itself is usually not very confirmatory in nature, unless you can see that that mass has completely lost its identity. In case of prostate cancer, I'll give you that example because again I work on it, so I'm more familiar with it. There, this technique is used, pathological sections are used, and a grading is done. If it is interesting to you, read about it. It's called Gleason grading. So the same pathologist, they take two sections of the same patient's tissue, and they give two grades to it. So the final grade is given as a summation. So for example, 3 plus 4, the entire Gleason score is 7, but they are given 3 plus 4. What does it mean? 3 means some parts of the tissue are less severe, some parts are more severe, versus somebody who has extensively very, very high cancerous tissue and complete identity of the prostate is completely lost, then they would have much higher scores, say 6 plus 4, which means that that region is extremely cancerous and some regions are less cancerous. So it's just a way of grading. I hope I explained the question to you. If you have any further query, let me know.
No, ma'am, I understood it. Thank you.
Anybody else? Any questions? Anything, any doubts, any feedback? If you like, I had considered sharing some sample MCQ questions, but this it's not exactly it's not that type of a course. I can draft some, but I'm not sure how relevant it would be to you. But let me know if you want something else which is more helpful to you for your own courses or for some other exams you might be preparing for, and we'll try to mold the course accordingly. Any other doubts? Let me know. Okay, if not, then we'll be wrapping up the session for today. Thank you so much for joining. I hope it was helpful for you. Um, the recording will be saved and will be available. If there are any more doubts, please go ahead and